Firstly, thanks to CSO and Hansen for inviting me to speak today. Despite my very Italian name, I'm also Scottish, which is why my accent is as it is. It's a really exciting time in anterior eye right now in artificial intelligence. Just to give you a feel for how exciting I'm talking about, I recently organized a Keratoconus teaching event at which Bruce Allen, who many of you may know, was speaking. And he prefaced his very excellent, very good talk on grafts with, "This is the boring stuff." I want you to look at these guys, pointing over to Olivia and I, who are doing talks on artificial intelligence and scanning modalities, because this is where the excitement is right now. His talk was excellent, but he was quite self-deprecating. As I say, AI is making massive leaps forward right now in anterior eye, and even just in wider news, antibiotic discovery. We've recently discovered the first new antibiotic in decades, and it took hours to do what would have taken researchers years, maybe even longer to do. And good news for us, the next targets for this same strategy are Pseudomonas and staph, if you haven't read about that already. Some important things I want to communicate straight off the bat here is that AI and machine learning are only as good as the data we feed it and how well we train it. So if we put rubbish in, we'll get rubbish back out again. The second thing is that deep learning can really help us put our patients into boxes. We want to know who are the most urgent patients, who is likely to change, who is high risk. All of that can be done automatically. So just a few financial declarations on the back of this travel to this conference, but apologies for the long title here, but very broad, and I promise not to get too much into the detail. I am not a machine learning expert, so please no questions on the intricacies of machine learning, because I don't know very much about it. I'm an end user, so I'll try and keep this relevant. Before we get going though, I'd like to start with this little haiku. This is now all the rage at conferences. You've probably seen lots of people using ChatGPT to generate them a bit of content, which keeps people interested. But actually, this was quite good. I asked it to say, write me a haiku on the use of machine learning in keratoconus monitoring and detection. It's quite nice. I might just make it the motto of our clinic. You might be asking what the dinosaur's about. If we look close at this dinosaur, what you'll probably see is that I asked ChatGPT's artistic cousin DALL-E to draw me a dinosaur with keratoconus. Have a look at that left eye drops and tell me that's not a good depiction of keratoconus. One thing they're not good at though, if you've ever tried this, not good at hands, feet, digits, teeth, they get it all wrong. With humans, it's a bit scarier than it is with dinosaurs. So have a play around with that. So anyway, back on topic. Let's start with big data. We hear this term thrown around a lot in various fields, but what does it actually mean? When does data become big? Well, the accepted definition of big data is a data set that's basically too large to be dealt with by conventional methods, statistics. Across the NHS, we gather 25 million images of the eye every year. This fits the description perfectly. Now, we can use big data, we can describe big data using the 5 V's. Volume, velocity, variety, veracity, and value. Volume and velocity first. Routine clinical care generates huge data sets. Every single one of our patients has 3 MS39 scans on each eye, sometimes a pentacam, sometimes an endothelial cell count, every single visit. And they're there every 6 to 12 months. So we get longitudinal data from this. We can tell a lot about natural history of disease. We can tell a lot about progression. But the sheer volume of data we're gathering makes it completely impractical to actually use it all. As a result, we're using K1, K2, back K1, back K2, CCT and Kmax to look at keratoconus. And we're really doing ourselves a disservice. Variety next. So this is whether the data is structured, semi-structured, unstructured. We're gathering medical images. So it falls under a few of these different categories. Veracity or accuracy. We need our patients to trust us with this data, so we need to make sure that what we're gathering is accurate. And then what value can this offer? What will patients benefit? How will patients benefit? We need to make sure we communicate that message clearly too. Now, AI is, again, an umbrella term. We use it to mean lots of different things. It means a lot of different things to a lot of different people. But what we have under data sets, when we think of AI, we usually thinking about machine learning and deep learning. Deep learning is where things like neural networks, convolutional neural networks live, which are the things that will help us analyze these image data sets. And it's one of the things that was used by Pierce Keene's group in looking at retinal data. You may have seen the paper in Nature looking at segmentation of retinal images, retinal OCTs, using artificial intelligence techniques. It's really going to change the way that we manage these patients in Moorfields. And you can see why this happens. We've been taking these images for years. We've got a massive data set, and these techniques came along just the right time. So let's talk about big data again. Why are these neural networks useful? I'm going to really oversimplify this, so apologies for people that know a lot more about this, but if we take scenario A and scenario B, stats and maths are great as scenario A. We can break this group of ducks and pigeons up into two and model it mathematically really easily. Scenario B, stats and maths may struggle with a bit. This is where these neural networks come in. They can help to sort out our data. AI techniques are not new. We've been seeing them for longer than we probably have been thinking about them. We use them in surface detection. And this is also done in the Pentacam. I don't know what technique they use to do that, but surface detection exists there too. CSO use it in their Keratoconus display. And if you've never used this before, if you look down in the bottom right-hand side or bottom left, you'll see that the algorithm has classified this eye as having keratoconus. This was done using a fairly rigorous process where about 6,000 eyes and the ophthalmologist put these patients into 5 boxes. And clicking on this diagnosis will give you the probability that it fits into one of these 5 boxes. A good time to remember that this technology isn't perfect. It's only 6,000 eyes and it's only 3 ophthalmologists. We can always improve. But use these algorithms with a pinch of salt. You've got to remember how to interpret these scans yourself because it sometimes gets it wrong. A bad scan can throw these things off. Lastly, I just want to touch briefly on work that we did in Mirrorfields with all of our data that we gathered over the last 10 or so years. What we did was we took 5,000 or so patients and 8,000 eyes, and we took indices from our electronic medical record that we've been gathering from the Pentacam for the last 10 years. Again, K1, K2, back K1, back K2, etc., including refraction and visual acuity data. And we generated this, and this is available to try. So if you want to have a look on the website, this is an interactive site, which I'm not going to show you today just for ease. But what you do here is you put in the patient's age, you put in various values taken from tomography, and it will give you the probability that that patient is likely to need cross-linking or not within 5 years. This is something that probably clinically we could have figured out ourselves anyway, but as far as messaging to patients is concerned, this is very powerful. If you've got a patient in front of you who says, my left eye is actually okay, I'd rather not have cross-linking, showing them this will help you convince them that actually what you know to be true is the case. So now to what I'm actually here to talk about, which is Ensay, the Health Data Research Hub for Eye Health. There is a video here which I'm hoping is going to work, so I did test it a minute ago, but we'll try. Very short video which will give a better explanation of what this program actually is than I could.
Our hub is focused on eye disease and the new science of oculomics. That's using our ultra-high resolution scanning systems to bring new insights into some of the most serious diseases of our time, things like diabetes and dementia.
In 2016, Moorfields Eye Hospital initiated a collaboration with Google DeepMind, which allowed us to develop an algorithm that could diagnose many of the commonest causes of blindness. With this hub, we want to share what we've learned from that experience on a national level.
So based on big data, we're hoping that we'll be able to individualize for patients what treatment they need, when they need it. And that will be a true benefit in terms of vision outcomes and delivery of care.
one thing that really attracted me to join this fantastic group of partners is the collective vision that we can all work together, making the data set available to a wider group of participants. And that means a lot of trust. Trust not only among the partners themselves, but actually all the patient data and that of the general population that will be collected will be handled in a safe and secure manner.
The hub will have a very strong approach to data safety and security, and that will be founded on a number of principles. For the application of new technologies such as AI in healthcare to be successful, they have to put patients first. The transparency about the use of patient data has to be embedded at every stage of the process.
Many of you will have noticed the emphasis there on a few key words. Ensay was built around what they consider to be their North Star or guiding principle, which is that delivering benefit to patients through improving safe, efficient access to this data for research. If you look at their mission statement on their website, you'll see that there's a lot of words which chime well with patients. There is unfortunately a lot of mistrust among patient groups, not just diffuse, but very specific to certain demographics, which is really our fault. When this was first tried a few years ago in NHS, the communication was poor and there was a lot of mistrust as a result. This risks introducing very serious bias into our data sets. If we've got patients opting out from certain demographics en masse, then we're going to have a big problem when it comes to these systems being accurate. A famous BBC technology correspondent in the UK once gave a really good example at a talk. He said, if you ask a patient in 2018, do you mind me having access to your anonymized data for the purposes of research? A significant proportion would have said no. If you asked them in 2020, when they were developing COVID vaccines, the same question, a significant proportion would have said yes. There is an element of selfishness to this. People want to be able to help their own condition, and actually that's one of the reasons why at Moorfields this has been a success. The patients who are signed up know that use of their data may help develop treatments to treat them, as well as benefiting the wider community. So the current landscape is mainly retinal, and you can see why. Retinal disease is a much bigger deal globally than corneal disease, you could argue. I'm very anterior eye, so I have a problem saying that, but it's true. Preventable blindness is a big problem when it comes to the retina, which is why a lot of this work has been focused there. Interestingly though, in anterior segment, less than 10% of open access data sets, that's 7 by the way, it's not a big number, address anterior segment disease, and only one of these addresses keratoconus. It's a tiny little database of 280 eyes with no images. We can do much better than that, and that's where this project comes in. We recently got funded by ESWIS to run a massive project with Ensay, AS's anterior segment, to look at image data in anterior eye. One of our first objectives is already well in progress. I recently extracted all of the data from our MS39 database. That's approximately 176,000 scans of 16,800 patients. I did that in 3 days with a very low spec computer. That was incredibly satisfying. Contrast that with my attempt to get the Pentacam data out, which took 3 years. I managed to get 38% of the data, and I gave up because it just wasn't happening. Our second objective is to create a large, high-quality open access data set with labeled images. All of these images are labeled by clinicians in the clinic. And this will give us a huge data set, one of the biggest in Europe, given that we have around 7,000 active keratoconus monitoring patients on the books. Lastly, we get to the fun part, which is where we get to play around with this data. Anyone that's tried Costruzione deep learning or is aware of it will be aware that it's incredibly easy, very accessible to anyone, including fairly clueless clinicians. Just as an example of what we could do, so if we have a look at this scan, now we take 3 scans per patient in the clinics to get a better measure of precision. This was work done by Stephen Kay on pentacam data, which we are replicating in MS39 and hope to do some work to study it too. Top on the right-hand side, we've got dates, individual scans, and here we've got the comparison of the two time points. There's something odd going on here. We've got change, but we don't really know why. If we compare the same eye to a different scan taken in the same day, it disappears. Now, both of these were considered by the machine to be good scans. The algorithm can only detect bad scans so much, but what if we added AI? Have a look at the reason why this happened. The placebo image here is distorted. You maybe can't see that from where you're sitting, but there's the good scan, and there's the bad one. Tear film is a mess, which is why we got that steepening and flattening. Operators can sometimes see that. Clinicians rarely see it because they're too busy looking at the color maps, and the software can't always see it. So we need something else, and this is where AI could come in. So why do we use the MS39? I've alluded to this a little bit already. On the face of it, when you compare spec, there isn't a huge difference. Obviously, the addition of OCT is game-changing. We can look at epithelial thickness, we can look at other things with a lot more accuracy than shine flood can. Placebo rings also add a lot more because nothing will give you anterior curvature more accurately than a placebo ring. Sections are only so good, which is why the MS39 uses placebo to gather information about the anterior part, and posterior seg is done with OCT. The deal breakers, though, and one of the reasons why we've managed to convince our trust to make the switch, was that 96 to 98,000 patients cannot run on a Microsoft Access database. That's why I had to stop at 35%, 40% to get this data out. It's not fit for purpose. We need more robust database architecture in order to make this work. We also need to be able to export the data. We tried and failed to get the image data from the pentacams when our first iteration of this study, so we had to move on. The third reason is we really need to get this data to improve these algorithms in anterior segment. They're very good at posterior, but we need to get better at anterior. Now, just before I finish up, the dinosaur's back to talk about K1 and K2. I have a bit of a problem with K1 and K2. They're my nemesis. I rarely let a talk on anterior segment go by without slamming them somewhere, so apologies to anyone that really loves K1 and K2, but I'm sure you'll all have seen that gradually enlarging cones, for example, here, would be completely missed by K1 and K2. While artificial intelligence can tell us about the whole eye and all the data points simultaneously, eventually, we're not there yet, but in the meantime, there are better ways of doing this. We've got things like Symmetry Index, which is available on more than one platform. We've got things like Center Surround Index, which will see these cones expanding before K1 and K2 are even wise to it at all. One of the things that we're planning to publish in a few months is the repeatability of all of these indices. There's very well published data on repeatability of K1 and K2, but given how irrelevant I find them to be, I want to know how repeatable these are, because it's only once we know that can we start to use them in progression monitoring. And hopefully also with this data that we can provide, CSO may be able to add some statistics to their keratoconus follow-up module as they develop it. So thank you for giving the opportunity to speak, and that's, I think, all I have.